Good afternoon. Welcome back to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine at UCSF. This is a kickoff to our new academic year, and so we will be back here with Grand Rounds weekly for the next 9 months or so. I hope you will turn this into your weekly habit. We're, based on the experience we had with COVID over the past year, we're sort of upping our game and got some fantastic sessions planned for you. Some of them will be COVID, some of them will not be, but be other really interesting issues in healthcare that I think you'll want to learn about and hear about from our speakers. Just a little bit of an advanced notice. Today will be a COVID session. We'll do another one on October 14th with our friend Ashish Jha. He and I will chat for an hour, so put that on your calendar for October 14th. Next week, we'll do one of our clinical problem-solving exercises where we present an unknown to Robbie Geha, one of our superb clinician educators. The week after that, on September 23rd, we will do a session on the controversy over the new Alzheimer's drug with Rita Redberg talking about some of the policy and FDA approval issues, and Gil Rabinovici from neurology talking about some of the clinical aspects and the clinical data on that drug. The week after, on September 30th, we'll have Eddie Chang, the chair of the Department of Neurosurgery, talk about his remarkable research on the essence of speech and how the human brain comes up with speech, and what he and his group have done, which is develop a speech neuroprosthesis for people that are unable to speak, and obviously it's gotten worldwide attention. So a lot of really interesting, cool stuff coming up, but let's focus on today. I'm not going to spend any time going through why we're talking about COVID still. When we signed off in May, we were hoping that maybe we would be over the worst of it and maybe a ripple of COVID here and there, but clearly that has not been how the summer has gone. So felt like it was time to bring together three of our favorite speakers to update us on where things are with COVID. I can be brief with their bios because you've met them before. First will be George Rutherford, who will give us a short talk on the state of the pandemic and this fourth surge. George is a professor in Epi and Biostat and serves as medical director of our prevention and public health group, and has been our go-to person for all things COVID epidemiology for the last year and a half. We'll also have Peter Chin Hong. Peter is professor of medicine in our division of infectious diseases at UCSF Health. He's also associate dean for regional campuses at the UCSF School of Medicine, and has been a go-to person for us on clinical and other aspects of the pandemic, as he has been for the media, as has our third speaker, Monica Gandhi, who is professor of medicine, associate division chief of the division of HIV, infectious disease, and global medicine based at Zuckerberg San Francisco General. She also directs the UCSF-Gladstone Center for AIDS Research and is the medical director of the HIV clinic. So these are three absolute world-class experts. No surprise that they have been essential communicators about the pandemic, both locally and to the media, nationally and internationally. And so we're thrilled to have them here to educate us about what's going on. And the what's going on part, we will try to cover as much as we can in the next hour, everything from the current wave to the schools, to masking, to Delta, to Mu, to boosters. So I'll talk fast, they'll talk fast. If you have questions, please type them in the Q&A. We'll get to as many of yours as we can. And if you're interested, closed captioning is available at the bottom of the screen. So with that, I will turn it over to George Rutherford.
Thanks, Bob. Okay. So I had hoped that when we had broken in May that we'd be looking pretty good now. It's sort of good, but not great. And we need to be, this is going to continue to be a problem. We have had a fourth surge since May in the United States and in California. As you'll recall, back here in April and May, there was a surge in the upper Midwest that probably really represented a fourth surge, although it may have been the tail of this sort of big winter surge. We did not see the same thing in California, but have nonetheless have had a surge through July and August. The United States right now, is running at more than 140,000 cases a day, with more than 1,500 cases a day. California is at about a little bit more than 10,000 cases a day, and has clearly turned down. The U.S. has seemingly turned down, although there's this kind of really jagged sawtooth pattern to cases. And it's a little unsure whether we can say this is a true turn down or not. The cautionary tale here is from the United Kingdom, where they had a very similar pattern with a surge, a drop down across the summer, a later summer surge, a decline, which like we're seeing now, but then it went right back up again. And I just want to say, we need to be careful that this doesn't happen here. In the UK, 65% of the entire population is fully vaccinated, whereas in the US right now, this morning, 53% of the entire population is totally vaccinated. So we are at risk for this happening, and it's going to take some concerted effort to keep it from not happening. Where are cases going on now in the US? Well, they're going all through the South, the Southeast, up in here into the lower Midwest, but also in the Intermountain West with states like Wyoming and Utah, Nevada, Idaho, and then even the sort of northern and eastern tiers of California being quite heavily affected. And this is per 100,000. Cases in Florida are starting to come down somewhat, which is most welcome. But it's, with the hurricane that's gone through and flooding and all those problems, it's unclear how that's going to affect the Gulf Coast. One thing that's come out is that this surge has affected children. These are data that just came out from CDC, and they're showing a surge in 0 to 17-year-olds out here in August. But if you look by state, and if you divide the states into quartiles, the states, the quarter of the states with the lowest vaccination coverage have the highest risk for ED visits. Sorry, this is for emergency department visits. I realize this is medicine grand round, so everybody thinks it's something else. For emergency department visits with 3.3 times higher odds and 3.7 times higher admissions in the states with the lowest levels of vaccination. California, by the way, is up in this highest tier. Here in California, as I said, this is a disease of the kind of the northern and eastern more tier with big surges in Del Norte, in Siskiyou, Tehama, Colusa, Sutter and Yuba, and even down here in Kings County. But there's a lot in Shasta and some of these other big things. The big population center in this part of the world is here in Redding. In the Bay Area, we're doing quite well, although Contra Costa and Solano are lagging behind somewhat, particularly Solano County. And in Southern California, Ventura, Los Angeles, Orange are doing well on a per capita basis. Overall, the R sub E for California, the effective reproductive number, is less than 1. We have a test positivity rate of about 4.5%, which is coming down. And we've had a flattening out of hospitalizations with only a 3% change over the last 14 days. In the Bay Area, only 2 counties have, this is jumping around. Alameda has declining case rates, as do Marin and Napa. San Francisco itself has had 70 more cases over the last week. But everybody's doing pretty well. All this R sub E's, except for a couple, like in Solano, are at or nearer below 1. The percentage of tests that are positive, again, with the exception of Solano, are all under 4. And you can see how this tracks with the percentage of the population that has had a first dose of vaccine. So here in Marin, where it's highest, this is where the one of the lowest for the percentage positive. Okay. In California, we've administered 46.6 million doses of vaccine. We're flattening out here at around 75 to 80,000 doses a day. 65.8% of Californians have received 1 dose or more, and 57.4% have been fully vaccinated, which is, by the way, less than in the United Kingdom. In San Francisco, 79.5% have had 1 dose or more, and 73.3% of everybody, including children, are fully vaccinated. And here you can see the data for the this is for California, and the highest 8 counties are all Bay Area counties, and then you get to Imperial and San Diego. So that's all. I think that's good news. We're pushing, although it's not kind of surging back up quite like we'd hope. The vaccinations are indeed climbing. The problem we're facing is Delta, the Delta variant, and the Delta variant is big trouble. It's become essentially the only variant circulating in the United States, and over here in Region 9, which includes California as well as Arizona, Hawaii, Nevada, and the Pacific territories. It's 99.5% of all the isolates that have been sequenced. So we've entered a phase where Delta has completely overwhelmed everything else, and it's not budging. So kind of what's going on, just to summarize what's going on in the US, there's the rise of the much more transmissible Delta variant. Now it's almost 100% of isolates in the US. We have a problem with failure to vaccinate, which is far more important than vaccine failure. We have a continued mixing of unvaccinated people with resultant transmission. And I saw that the Sturgis Harley-Davidson annual motorcycle rally happened last month in South Dakota. So that's probably not a good thing. We have had less than full adherence to non-pharmaceutical interventions. We've had a failure to develop immunity in some immunocompromised individuals. And this has led to a recommendation for an additional dose in the primary series of the mRNA vaccines. There's some mixed evidence of declining vaccine effectiveness that's been temporarily associated with the rise of the Delta virus. It's unclear whether that's waning, first of all, whether it's anything at all, whether it's waning immunity or whether they're escape mutations. And this has led to the whole discussion of breakthrough infections, which are still uncommon, but it's likely to prompt action at the federal level. This is a study that was just published last week in the New England Journal from UC San Diego, looking at vaccine effectiveness by month among healthcare workers. These are mRNA vaccines. So 94%, 96%, 96%, 94%, and then 66% in July. There's similar data from a number of places that have similar levels of declining vaccine effectiveness. However, we're still seeing most of the cases in people who are unvaccinated and most of the hospitalizations in people who are unvaccinated. This takes us up to almost the end of July from Los Angeles County. The dashed line are people who are unvaccinated. These are infection rates, and the dark blue line is the people who are fully vaccinated. And it's actually 4.9 times higher in numbers of cases among the unvaccinated. And hospitalizations are 29.4 times higher among the unvaccinated. And these are hard data from Los Angeles. So I think it's probably consistent with what we're seeing. So the US is considering recommending a third dose of mRNA vaccines. There are two issues. One is non-response among solid organ transplant recipients and other immunosuppressed patients. And the second is this issue of waning immunity. Again, we'll have some discussion about that. There's a recommendation for an additional dose after the primary series for transplant recipients and immunosuppressed patients immediately. And then there's this discussion about a third dose for everyone else 6 to 8 months after their second dose beginning on September 20th. This would recapitulate the rollout from last winter with long-term care residents and healthcare workers being vaccinated first, then adults over 70, 75 and over, and a frontline essential workers next, then adults 65 and over, all essential workers and some of those younger people with high-risk medical conditions. Right now, there's an active discussion of whether this should just be for people who receive the Pfizer vaccine only. And there's some interesting reasons for that. And meanwhile, for those of you who got J&J vaccine, we're awaiting the results of a 1 versus 2 dose trial that they did. And at least at San Francisco General, SFDPH has gone ahead and offered mRNA vaccines to people who had a single dose of J&J vaccine. This is something that's evolving as we're talking. And so finally, where does this put us? This is the Institute for Health Metrics and Evaluation at the University of Washington. Their most likely scenario, which is the middle one, which has 57% of Americans fully vaccinated by December 31st, and that mask use is roughly comparable over time. It has this, still not coming all the way down. These are case counts of tens of thousands per day. The worst case scenario, this is where everybody stops wearing masks, and the best case scenario is when we can keep masks on people. So we'll have to see how this plays out. This does not include, in the models, it doesn't include issues of schools per se, which are a bit of a wild card as to how they'll play out. What I'm happy to say is that at least in my dealings with a handful of school districts, including large school districts, there is very little in-school transmission. Almost all the kids who've been found to be infected have been infected either in their families or in the community, and not in the schools per se. There are a handful that are, but it's only a handful. So I'll stop there and happy to hop back on.
When you stay back on, George, and let's bring on Peter and Monica. And let me start with you just to clarify. It's first a terrific and sets us up beautifully for a whole lot of questions that will come. Why do surges come down? You hear talk that you've sort of reached a level of immunity, but like really and then you hear talk it's just fear of God, but like why did that start on that day? And then why did the UK go back up? So do you have any good explanation for why it seems like these last 2 to 3 months and they always come down?
The New York Times had a really interesting article that said that all these Delta surges are on 2-month timeframes. They go up, they go down, they go up, they go down. And there was some postulation that it might be biological. I doubt that. I think that this is really, there's going to be some biology to it, obviously, but I think it's also behavioral. People wearing masks, maintaining, socially distancing, but more importantly, getting vaccinated and using this as a spur to get vaccinated. So it is what it is. And I think we could go on, and Delta is so transmissible that I think you could easily, without any kind of, if you did no abatement at all, they would basically find almost everybody who was unvaccinated and give them Delta virus. So I think the fact that it's coming down bespeaks our efforts to control it. Right.
All right, let's turn to
just one quick thing.
ahead,
I could just say one thing
please.
about that, because I think it's really interesting to see the cases coming down in, like you just showed, in California and San Francisco, but the cases came down in Missouri first, and that's actually where they rose first. They banned a mask mandate. There was no capacity limits, and there wasn't actually a lot of behavior change, and their vaccines didn't go up that much as we would have liked. They did go up some. There is, of course, a role of people getting infected, natural immunity bringing cases down. India had 4% vaccination rate in early March when the Delta variant rose. And George, I wish it was vaccination, but unfortunately we just didn't have the vaccine supply there to provide everyone with vaccines. There was behavior change, but it's 1.37 billion people. A lot of people are in close proximity. And of course it is a lot, some of it in lower vaccination rates, regions of the surges coming down is natural immunity.
So just maybe complete the dots there though, in terms of Missouri. So if you say, people didn't get vaccinated that fast, and they didn't change behavior, and they didn't wear masks. So when it comes down, what is your hypothesis about what's going on?
That essentially there are people who get sick from it and go into the hospital, but there are other people who have mild disease and get immune. And essentially when it does take some time, it takes 2 months. This happened in India as well. But immunity will bring down a pandemic. We all want it to be through vaccination.
Right. So natural infection immunity, you think, is some sort of level of immunity through natural infection, and that is
correct.
Yeah, I agree with Monica too. That natural immunity has been underestimated. Maybe it's not as sexy, or it's kind of taboo to talk about it. But I'm particularly struck by the contrast between Michigan and Florida, for example. Very similar demographics, but if you remember, in Michigan, before the Delta surge, they had that whole huge winter alpha surge with indoor sports. And then now people are like scratching their heads, why is Michigan doing so well, generally speaking, compared to very similar vaccination rate of Florida? So that speaks to that as well.
Yeah. Yeah. Let me ask, one of the three of you is getting a lot of emails that's pinging. So if you can turn that off, that would be great. Let me start, ask Peter and Monica, if you're anything like me, probably George too, you're getting a ton of calls from friends and family, some that you've forgotten about, and they have a question for you, like, what do I do? This happened. So what is the most common question that you're getting from the people that you haven't heard from in 20 years? And how do you answer it? Peter, do you have one?
Yeah, I mean, the most common question is, for me, is should I travel? And I think that's, people are itching to travel. They've been vaccinated. We thought the world would be open and we'd all go forth and count. So specifically, a lot of people recently with Mu in Colombia, they had booked tickets to go to Colombia and they are saying, should I cancel that trip to Cartagena? And so I've been getting a lot of questions around that.
And what do you tell?
I tell them, take your precautions. The level of disease in Colombia is not terrible. And it just because there's Mu there doesn't mean that, if you're going to a seaside city, you take your precautions, you use your disease mitigation strategies. I wouldn't necessarily cancel that trip. But again, this comes to like one of the points we're going to bring up, which is how do you live with the pandemic? How do you, manage disease rather than live under infection fear?
Yeah,
I
and
think the real answer to that
question. What do you tell about the flight, by the way? Are you convinced the flights are okay?
I think the flights are okay with multiple exchanges per hour, but what I'm worried about is the routes to the flight, the gate area, the concessions, the food court, the transport from the airport to the hotel. That's much more, if people really want to be risk averse in flights, sit by the window, turn on the vent, keep your mask on for most of the time, go to the bathroom before the flight and after the flight, but minimize going to the corridor and keep your head in one direction.
Keep your head in one direction. Okay, George, you were going to say?
I was going to say the real answer to your question is never turn down the opportunity to go to Cartagena.
Yeah.
It's a fabulous place.
One thing I would say about travel, because this is being asked of me too, you're absolutely right. Like, I totally agree with both of you that the air exchange is excellent on the plane. And I actually just, because I have an unvaccinated younger child, I always put the vent on. So that just brings in more, even though we're kind of cold. And then I'll be a little more masky on the plane. So when you travel on multiple international airlines, you actually need a KN95. So I think it's important to remember that not all masks are equal. KN95s are good masks. Double masks are good masks. So are like 2 pieces of cloth and a filter paper inside. So if he's unvaccinated, my younger child, then I'm going to be masky with him.
So I hadn't heard the term masky before. So let's get into maskiness just for while we're there. Then we'll get. I mean, this is going to go everywhere. I need to peel back and talk about Mu at some point. All right. So you're being masky. So tell me you were taking a flight to New York a couple of months ago when when things were a little bit lighter. You're taking it today, and you're maskier today. So exactly what does that mean in terms of what mask, and in terms of your behavior as it relates to the peanuts and the drink?
So a couple months ago, things were good. Things were so good between Alpha and Delta. I'm so sorry the Delta happened. And by the way, it happened because we don't have global vaccine equity, which we can talk about later. And so what happened is during Delta flights, when
you say Delta flights, are we talking about the airline or?
No, sorry.
Are you talking about Delta? We're talking about Delta Plus,
very clear
like
here,
Economy Plus.
Actually, Delta has better TV, but
Flights during the Delta era, is that what you're saying? Oh, I think you're frozen for me.
Yeah, Delta's an unfortunate name. It's like having a baseball relief pitcher named Wachter.
You want to name your airline right now. All right, we'll get back to Monica when she reappears. Peter, let me peel back to you for a second, then maybe George as well. Mu. So you mentioned it. What is it? Is it a scariant or something we really care about, and why?
So I think for Mu, first of all, it has a Greek letter, so that already elevates it above other things like C12, which doesn't even have a Greek letter yet. It is a variant of interest designated by the WHO, not a variant of concern yet, higher level. And then the CDC hasn't said any variant of interest or concern yet. very low. All states have reported it as far as I know, but much more common and very regional. So like northern part of South America, mainly Colombia, some Ecuador, maybe a smattering of other countries, maybe 40, but less than 1% of cases globally so far. And if Mu and Delta went in a boxing ring, Delta is going to win. If I had to be a variant right now in 2021, I'd want to emphasize transmissibility over vaccine evasion, because so far they've only these variants only emphasize one thing for gamma and beta, and like Mu, and Lambda to some extent, it's like a little bit more vaccine evading, but Delta is like so transmissible that it makes all the other variants cower in fear.
I call it the variant to rule them all.
So that the idea is you might hear about Mu, and maybe it is a little bit more able to evade immunity than Delta is, but as long as Delta is so much more transmissible then Delta is going to win the battle and be the main variant that we see. Is that clear that Mu is not that transmissible yet?
No, I mean, I think we probably don't know many things about Mu, and that's being studied, but so far so good. It's not clear if it's more transmissible yet, although there are early reports in Colombia that it's already cresting and going down. So, I'm taking it with a small grain of salt.
Okay.
The reason I think it's clear it's not more transmissible is it never won. Like, it's actually been here since January, and Delta was out a little later, and it hasn't been able to take it over.
So you're able to tell, because if it was more transmissible, it would actually.
Yeah, because if you remember with Delta, it's also not only the cross-sectional snapshot, it's the tempo. So if you remember in May, Delta was 5%, and then the next month it was 50%. So the rate of increase was breathtaking, which we haven't really seen with Mu per se.
In India, we called it a wall. I mean, it wasn't a word, it was a wall.
Yeah.
So that's Delta. Mu's been out since January. I don't think it's going to win.
Okay, George, anything you want to add on Mu?
No, they're absolutely right. I mean, the next letter is Nu in the Greek alphabet. By
Nu, all right. I thought that's in the Hebrew alphabet, but we'll get back to Monica. You were, by the way, I just while you froze, I checked Delta's stock went down about 5 points. So when you were talking about a Delta flight, you're talking about the virus, a flight in the era of Delta. Is that correct? All right. Now you're on both of them. There we are. Okay.
Monica is ubiquitous. It serves
it's
right.
Incredible.
She's
everywhere.
In more than one square.
Okay, why am I more masky? So
why are you more masky, and what does that mean practically? What are you actually doing?
Yes, so I did fly in both times, and everyone was happily flying with the less masky, between Alpha and Delta. So why have a couple of reasons to be more conscious about the type of mask you wear right now. Number one, Delta, it's very extreme if you have 60,000 people come in at once and have and all the windows closed and have a lot of intimacy and have no masks, and there's mixed vaccination and unvaccinated people, which was the Provincetown outbreak. You could have a high breakthrough infection rate. That is as stressful as a situation on the vaccines that you can get. And no one, there were 7 hospitalizations, they all did fine. Luckily, no one died. And it really is a stress test of how well these vaccines are working against severe disease. Now, in normal circumstances where you're just doing what you're doing and you're not going inside and doing all of that with mixed vaccinated and unvaccinated, the breakthrough rate is, I know, we all saw this New York Times article, but it was compiling data from Utah, from Virginia, from Washington State, and the breakthrough rate will always depend on your region. So higher rates of community transmission, you'll have higher breakthroughs, but it's 1 in 5,000 in high incidence regions. Somewhere like San Francisco, 1 in 10,000.
Per day.
Per day, right. And as our cases have gone down, that will go down. And so you have to decide what your level of comfort is with that risk. I, as a healthcare worker, actually have very little comfort with risk because I have to go to work. But if I weren't a healthcare worker, I was very comfortable with my parents being here with that low risk that they had. They were just here last week. But what we do inside is we do masks that are really been more proven to work. So there was a large cluster randomized village level controlled trial, the Bangladesh RCT. It was performed in Bangladesh. It was just in preprint last week.
Mhm.
But the reason it was important is it compared cloth masks to surgical masks in a population level. So it's hard to tell, like, who knows, everyone who's wearing it, they tried to increase use, but at least those over 50 were protected from symptomatic infection, but with surgical masks, not cloth masks. So I would use a surgical mask, and I actually bought these pink ones because I'm so tired of blue. And then if I really was in a high stress situation, like inside around a lot of unvaccinated people, I would actually put two together. I would put this together with a cloth mask. We had done some research on how that really blocks out virus more, or take a cloth mask and put filter paper inside of it. They're super easy to get on Amazon, and you have two different mechanisms of repelling the virus: electrostatic from the filter type paper, polypropylene material, and then the cloth is a physical blockage. And that's what I do on my unvaccinated child on planes during Delta.
So just to be clear, cloth close to you, excuse me, surgical on your face, cloth, tight fitting cloth on top of it. And that's,
it can be actually either way. And I actually prefer the surgical on top because then I can reuse it. Because I do wear lipstick. And sort of environmental concerns, but it's really the principles behind two things: increased fit, so closer to your face. You could also tuck in the surgical mask, and increased filtration by the two layers.
So one of our colleagues has famously been writing about the concerns about the level of evidence for masking and some concerns about harm that masks can cause in kids. Can somebody address whether they have those concerns? Peter, you want to start, and then we give it to Monica?
I was looking at Jorge being the first.
George, you want to? Our only pediatrician here, so.
I just having been on the American Academy of Pediatrics website this morning to answer this question for BuzzFeed.
Yeah.
They say it's almost no situation. I mean, if you have to be over 2, okay. If you're under 2, there's a suffocation risk. Okay, we give you that one. And certainly some very developmentally delayed children may have similar risks of suffocation. But for speech or language impairment, no evidence. For children with marginal lung function, no evidence.
No evidence that they harm you in any material way.
Yeah, no harm. And not getting this disease is a huge help.
Yeah.
Just to be fair, though, to those criticisms, because I really do want to be fair, that a lot of what this is based on is that, let's please remember that the UK, Europe, do not mask children under 12, and the WHO do not mask children under 5. So when various practices occur across a world, it is fair to question, do children need it as much as adults? Even in the Bangladesh RCT, it was adults who benefited for symptomatic reduction in COVID over 50.
So what's your bottom line on the state of the evidence around kids and masking? So that mandatory, this sort of goes into the issue of mandatory masking in school.
You know, this is my bottom line on it, is that I think that I want children back in school. I don't think I've ever made a secret about that. And because of that, I think it's best to have masks in school, because I don't want distancing, which is why the California DPH said everyone masks when Delta came out, and no distancing, because that's the least effective of our strategies. There are theoretical benefits, of course, sorry to use the word condom in the same word as school, but condoms we've never tested, but we know that condoms block transmission. So there's physical science reasons to believe it. And I just want children back in school. So I think masking right now is totally valid. I do think that we need metrics to remove masks. We're a mixed society. Not everyone loves their children in masks. And metrics that are based on how communities are doing is the right thing to do to remove them, not just the metric of children being vaccinated. And I also believe that we should be fair, just like we were just fair about natural immunity, Peter. We should be fair about what happens in other countries and acknowledge that, not say, oh, it doesn't matter that other countries don't mask children. We're the right people. We should acknowledge that variability.
I mean, I think everyone's talking the same thing, which is that there are multiple strategies to protect kids in school. Now, if the UK is not masking, they're doing other things much better than we are in lieu of not masking. So they're doing quarantining, contact tracing, a lot of testing in the UK. We can't really have enough tests to deliver that uniformly. So I think when you read the headlines, UK isn't using masks in schools, it's because they're using other disease mitigation strategies. And it's, to me, it's all about Swiss cheese. You have
Later.
ventilation, you have, sure, if you can distance your desk, that's great. But if you can't do robust testing, contact tracing, and quarantining like the UK does, the mask is relatively cheap and expensive. And kids, actually, from what I understand, they wear it and they don't complain. That's what.
Okay.
Yeah.
And just to be clear, Monica, when you talked about condoms, you're talking about in HIV, and you were talking, you're not putting a condom over your face. That's
No, I just really that's why I was hesitating doing that. I'm sorry.
We're mixing
never had a
diseases and
randomized
uses
controlled
here. I just want to
trial.
be clear.
We've
Okay.
never had an RCT of condoms.
I got it.
Because it's just basic common sense. That
George, take it in terms of, so Peter mentioned the idea that other countries are doing more testing.
Yeah.
Why are we not? I'm hearing reports out of Austria and Germany that it's, there is absolutely ubiquitous, antigen testing everywhere. You walk into the gym, you walk into the school, you walk into the supermarket. What's gone on here to make that so hard?
Well, I mean, other countries like Los Angeles test kids every week to go to school. And the UK does this sort of modified quarantine. They have another word for it, but they basically test kids once a day, every day to keep them in school. I think it's something
been exposed, just to be clear.
Yeah, if they've been exposed. Yeah, exactly.
Right.
Sorry. Right. Yeah. So I think it's something that we're that we need to use more of. I got a note today that said the state just ordered another 7 million doses of 7 million Binax Now kits. So we may have the supplies to do it. I think it's just been underutilized, and we need to push on it some more.
And if you were having a testing strategy for the schools or for your workplace, what would it be? Would it be PCR? Would it be the antigen? Would it be twice a week, once a week, every day? How would you work?
Depends on how much money you have, right? It's, so if you're the NBA.
You're balancing, nobody has unlimited resource. You're balancing resources with what you think is good enough efficacy to make a difference. What would the?
Yeah, I think antigen testing is the way to go, and I'd probably do it two times a week or every 3 days, something like that.
Peter, yeah.
I mean, to me, it depends on what else you have going on. So like at Stanford, they're doing, and Jorge knows this because we talked about this together, but in Stanford, they're doing once weekly testing, I think, but they also have a vaccine mandate. So if you don't have anything else, then you probably have to do more frequent testing to kind of be more reassured in general.
I'd really like to agree with what you just said, Peter, because I just do want to point out that San Francisco Department of Public Health just put out data 33 minutes ago. That was breaking news that showed really low rates of transmission in schools, just like George had said. Even as we have started our schools, August 16th was the date of school opening here in SFUSD. They don't do asymptomatic testing, which is a decision they made because of when we get into lower prevalences, you have a false positive rate. What they're doing is that they're doing the quarantine kids if they've had an exposure. What the private schools are doing right now is because they have plenty of Binax, they will call test to stay, which I think is a really important strategy, that if you've been exposed, you get antigen testing so to be able to stay in school. And unfortunately, SFUSD has not yet done that, and they're keeping kids out of school for 10 days. What I'm really hoping is that they'll take these 7 million tests that you just said from the California DPH and please use test to stay strategies, which are really successful around the country. Boston's doing it, trying to do it, at least UK's been doing it. If you've had an exposure, it's not by asymptomatic. There's exposure, you test to stay.
Yeah.
I'd like to introduce one last thing in that whole SF.
There's a cluster randomized trial from the UK about this.
Situation is that one of the things that we do have, the reason why I think it's been so amazing in schools here is because the adolescents are so highly vaccinated too. So you have a bigger wall of immunity around the kids under 12 in SF versus like many other places around the country where they're doing less than 50% of the adolescents. Whereas in SF, it's like more than 90%. Could you believe that?
And teacher mandates essentially for vaccines. I mean, I know you can test out, but that's essentially as much as you can trying to go towards a mandate for teachers, which if anywhere there's going to be a mandate besides healthcare workers, it seems like that's where it should be.
And this test to stay strategy, I mean, one of the things we're running into in a healthcare workforce is, we're telling people you have a sniffle, you got to stay home. Should we be doing antigen testing on people?
Yes.
And if you have sniffle, you do an antigen test. If you're negative, it's okay to work?
We need to stay at work. I mean, that there was some real problems when we had some breakthroughs here in at the San Francisco General. So I think that test to stay strategy in right now, while we're going through Delta, in any situation is a great idea.
Okay.
Yeah, I mean, and it doesn't need to necessarily be antigen testing. If you have all the money in the world, you can do PCR testing. That's fine too.
I do like antigen though, for the reasons you said, that essentially it's more likely to say you're infectious, which is the entire point of why you would keep someone out of school, is they could be infectious, because a PCR test will give you one dead virus in your nose. Remember that.
And also it's cheaper. It's,
right away.
Instead of upscale, and point of care.
Okay, let us switch to vaccine efficacy. Is it waning? Is it waning for symptomatic? Is it waning for severe? Is it waning differently for Pfizer, Moderna, J&J, for natural infection? A lot of stuff to cover, and then we'll obviously get to boosters. So, somebody want to summarize what they think the literature shows in terms of is the vaccine efficacy waning for both symptomatic and overall infections? George, you hinted at this a little bit. What anybody else want to weigh in on their take on the literature?
I can do this quickly. Is that I think that in general, you have to divide it into, like you said, severe disease and symptomatic disease, where you can get like a cold or a flu. So let's go back to severe disease. I think the data is very consistent that we are not having waning effectiveness against severe disease in general. And that means from the UK, Canada, the US, there was a CDC New York study, 20.2 times more likely to be hospitalized if you're in LA. So lots of really unvaccinated people being in the hospital, not vaccinated as much. So I think we have good severe disease. That actually maps onto one arm of our immune system, which is T cells, and they tend to stay up for a long time. So then what's going on with more breakthrough infections? I do think the Pfizer vaccine, because it was given 3 weeks apart, at least in one study, in a JAMA study comparing to Moderna, had lower antibodies than Moderna, and it could have been that shorter interval, let alone Moderna's 3 times the dose. And then, and remember Israel, where we're seeing most of this waning against mild disease, only used Pfizer. And then there was a Mayo Clinic study that said that people who had more reinfections in the Mayo Clinic system, if they got the Pfizer than the Moderna vaccine. So I think that 3 weeks apart may be too short. I think a lot of vaccinologists were saying that even at the beginning. You said that, Bob. So because of that, it's possible that that if you have the Pfizer vaccine, you may be more likely for a mild breakthrough, which is, I think it's prudent to put back masks while we're in the Delta surge in the inside setting. But whether we need to boost or not, I know we'll get into that. But I will say that mild and severe are different, and they're armed by they're protected by different arms of the immune system. Antibodies from B cells protect you against mild disease, and they do wane with time. It's totally natural. It's what the immune system does. Otherwise you couldn't move, you have too much protein. And so it's normal for that to happen. And it really is mild disease. The severe disease is being protected. So we have to talk about that.
Okay. Anybody want to add anything or disagree?
Yeah, I mean, I agree with Monica. And I mean, for me, the data is very robust, no matter how you slice and dice the pie, that severe disease, hospitalizations, and deaths are spectacularly prevented by the current vaccine strategy. I am very intrigued by the idea of interval between doses. And of course, you and the audience will probably remember that in the UK, they had no other choice but to delay the second doses. And they retrospectively looked at people who got the delayed dose versus people who got it in time. And at the time, I didn't really know what to make of the data because it was antibody levels. But they showed that the people who got the delayed had higher antibody levels than the people who got
even
it
with
on
Pfizer.
schedule. Yes.
Yeah, even with Pfizer. Yeah.
Okay, so if you told me, so I'm a 63-year-old guy, I got Pfizer 8 months ago. If you told me I could go to the Walgreens and get my booster now, I would leave this call and get it, because I still don't want even quote mild disease, because it's quote mild disease that, you know, you lose your sense of taste or smell for a month, or you feel like garbage for several days. You can transmit the infection, although at a lower rate than, probably a lower rate than an unvaccinated person. We don't know the probability of long COVID. Monica sort of made some comments about what that is, and maybe we have more information on that. But I don't even want mild disease if I can avoid it. When I hear people say the vaccines were never designed to prevent mild disease. I don't really care what they were designed for. If they did it before and they don't do it anymore, I want them to do it again, unless the treatment carries some risk, which as far as I can tell, a third dose carries next to no risk. So talk me out of why I should stay on the call if I get a call from Walgreens now that I can get my third shot right now. Monica, you want to tell me why that's not the right thing to do?
I think, yes. So I think that it is a couple of reasons. So one is that essentially, if you get a mild, your possibility of getting a mild breakthrough infection depends on the prevalence in your area. And 1 in 10,000 is very low right now in San Francisco. And that will go lower with time as the cases come down. And it's just a temporary fix because it's really just treating like the antibodies coming up in your nose, but they're going to go right back down again. And what really matters is what's called your memory, your cellular memory, your B cells and your T cells are there. We know it. We've like biopsied people's lymph nodes and bone marrow, and we know that these memory B cells are there. We know the T cells are there. And if you see the virus again, you'll fight it hopefully, and your antibodies will come right back up. Second reason is really, and we have to be fair about this, right? When Dr. Tedros from the WHO reiterated yesterday that please don't give third shots to rich people while we are waiting for just at least get 40% of people vaccinated in low-income countries, he's speaking to the fact that 2% of people in low-income countries have been vaccinated in sub-Saharan Africa. And you can just argue that what you just said is saying you get a third shot, Americans get a third shot to prevent a cold, but there are people who are dying every single day in massive amounts because we have no global vaccine equity. And the US is sitting on upwards by the end of the month of 1 billion surplus doses. It is geopolitically, I just can't imagine how that's going to look for anyone if we do this. And then the third thing that I really want to say is that, and I can wear a mask right now to prevent myself from being around someone where I can get a mild breakthrough. So I just need to wait a couple more weeks until those cases go down more, and then it's going to even be 1 in 40,000 chance. And finally, again, don't treat, I would just take those severe breakthrough infections. There's 7,000 in this country out of 173 million fully vaccinated. Figure out the demographics. It's so easy. Are they all Pfizer patients? Then give it to Pfizer people. Are they all immunocompromised? Are they all 63 and otherwise healthy? Are they 70 and have 2 medical conditions? Start with that group. And if they need to be in long-term care facilities, older people, immunocompromised people with multiple medical conditions, start with that group while we're sorting it out.
I want to layer some thoughts on Monica's comments as well too. And I'm sort of mixed about the booster shot. On one hand, there are lots of other disease vaccination paradigms where we do a prime and boost, and the prime is 0 and 1 month, and then the boost is like 6 months. At 6 months, hepatitis B, HPV, etc. So it makes kind of sense biologically, but then on the other hand, I'm looking at the data. So I think it all depends on if you want to be proactive or reactive. Right now, we're looking at the data and everything looks good. Is that slight waning in the older population for severe disease and hospitalizations and death in Israel? Maybe 91% versus in the 80s, if you believe that data, which hasn't been peer reviewed in the older population. Are we going to do, optimize immunization in that group, nursing home residents, older individuals, so they don't get into something in the future? Maybe that might be the solution. But regardless, I agree with Monica about the optics, even though we might have enough vaccines to kind of let's just lay out boosters for all. And I felt this way also because over the weekend, the Israeli Minister of Health started talking about a 4th booster, a 4th shot for the future. And maybe the green pass might expire after 2 or 3 doses, and they could program it that way. So I think that gave me some more room for thought, because again, if you think about antibodies going down to protect against mild disease, you probably have to get a booster every 6 months to really keep that up, or develop a nasal vaccine.
Okay. George, any thoughts on this?
Well, I mean, there's enlightened, there's global equity and there's enlightened self-interest. We have a border with 3 million people who live on it who are all unvaccinated. That would strike me as something that would be within our kind of our purview to want to take care of that little problem before we start passing out third doses to people who don't really need them. So I mean, I think you can. I mean, the global help, the global equity thing is fine, and if I were Dr. Tedros, I'd be saying the same thing. But I think if you want to look at it from a purely U.S. perspective, there are countries from which we have tremendous amount of immigration, including Haiti and the DR and Mexico. And, you know, we should be helping them with their vaccination programs. I think, and that's really directly within our self-interest.
I guess I'm still struggling with a couple of things. One on the equity side, you know, the argument's quite, you know, clear morally, but same thing is true for the way we manage hypertension, diabetes, cancer. You know, we don't say, maybe we should, that you're treating this cancer with this very effective but incredibly expensive chemotherapy, and you're not doing that to people in India or Africa. And so obviously the argument is somewhat different here, that somehow it's in our self-interest at some level, or in the world's interest, to get everybody vaccinated, and that's different than treating everybody's cancer.
That's true, right? With the global pandemic, that's true, because a variant will emerge, like it emerged in India with 4% of the population vaccinated. It will emerge elsewhere. So take morals and ethics out of it. It's a public health imperative.
Don't you? I guess the question is, you know, the question is it really? We're framing this at or versus and. You know, we're talking about 1 billion extra doses. You know, to use 100 million of them to give high-ish risk people a third dose. Are we really in a material, is this a symbolic act, or is it really materially going to change the nature of the risk of a variant over the next year? And if
I would give all 60-year-olds a booster, 60 and above, because that way we get you.
It makes me feel better. Obviously, it's not all about me, but
I'm serious, actually.
I see myself as a sort of reasonable test case of sort of where we draw the line.
No, that's what Israel did. Was
I mean, I really kind of mean that. Like, I mean, like, draw a line where because number one, right now the infighting looks really strange from the administration. Right. FDA saying one thing, HHS saying one thing. It's embarrassing. Like, we need to come together and just draw a line. If it's over 60, then do that. And that kind of, you get it all in that way, you know?
But the line is, I mean, it's got to be what's the evidence behind the line? The line is that there's a risk level of a certain population, whether it's comorbidities or age or whatever, that does say that the risk of a breakthrough is meaningfully, you know, can lead to a bad outcome in some way at a higher prevalence. I mean, part of what persuades me here is that we're talking about something that is very low risk and very low cost. And you know, and so it has a different feeling trying to sort of figure out why not give it to people. Yeah. I understand, but when I hear people say, you know, we should be concentrating, sometimes I make the domestic argument. We shouldn't give it to a third dose for a person who's already been vaccinated. We should concentrate on giving it to the unvaccinated. I'm trying to figure out, like, what does that mean? Yeah. Like, what have we been concentrating on that for 6 months? So,
but Bob, I do think one thing to not lose in the shuffle here is that, you know, people who are immunocompromised who are solid organ transplants need a third dose. Yeah. Period. Over.
They may need a fourth dose or a fifth dose.
They're going to need more. Yeah, they need a fifth dose.
Yeah.
Peter, what is the evidence in terms of them getting their third dose and it meaningfully creating community? How well is it working?
There are two sort of groups of evidence right now. More studies are being done. One from France, and then one from the Hopkins group. There's also one in University of Toronto. But essentially, it's if you are not, first of all, about 50% of people who are more severely immunocompromised would develop an antibody response. And of those unvaccinated people, if you give them a third shot, about anywhere from 30 to 50% of that group will respond. So again, there's, 50 to 70% of people who may not respond even after a third shot. So that's where the interesting idea about using monoclonal antibodies as bridge in some individuals might be interesting as well.
Okay, we're going to run out of time. I want to cover a few other issues in terms of efficacy and boosters. So how about Moderna? If let's say Monica has agreed that it's over 60, let's say is the number, who got Pfizer. Based on what we know about Moderna and some uncertainty about what the third dose should be, should we hold off on them until we figure out what the right dose is?
I think we're trying to figure that out now.
You're right. Yeah. They're debating between 150 micrograms. The dose for the first two is 100, because there are two possibilities why Moderna had higher antibodies and also the lower reinfection rate in the Mayo Clinic system, which is the higher dose is 3 times as high as 30 micrograms, which is Pfizer, or it is that longer duration, even 1 week makes a difference. And I think that I fundamentally, have you ever had a vaccine that's 3 weeks apart? There's not a single vaccine. The only, I mean, 1 month is minimum to prime the immune response. So I think it has a lot to do with duration. So to me, it makes it seem like maybe it doesn't matter, because when you get the booster of Pfizer, it's going to be way spaced out from your second dose. But the Moderna is interesting. There was some data that it really produces long-lasting CD8 cells over time. So I kind of like Moderna. I got Pfizer.
So, but are
I
you
got
saying
Moderna.
that Moderna might not need it because it maybe produces longer lasting immunity, either because we gave you a bigger dose than you needed, or we spaced it an extra week?
Yes, that's the question. I mean, because when we can talk about antibodies and B cells and T cells all we want, right? But we really want to look at reinfection rates. That's the clinical outcome that's of import. And that's why I'm asking, everyone's asking the CDC, please take those severe breakthroughs and tell us if they're all Pfizer. Tell us if they're all Johnson & Johnson, because poor Johnson & Johnson people always feel that they're being left out of the dialogue.
So let's
What if
go.
none of them are?
So at this moment, if you were a Moderna person, let's say you're 70 and you are at higher risk, and the Pfizer people have gotten their vaccine boosters endorsed, you would say, based on what we know now, I would hold off on Moderna, partly because you might still be better protected, and partly because we don't actually know what dose we should give you. Is that accurate? Peter, is that where you would be?
No, I actually would. I think if you're older than 60 and there's a booster approved, I might tell you to just go ahead and get it, because I'm not sure when that data will come out, and we're in the middle of, you know,
you get the original dose, you get the third sort of full-on dose, even though it might be more than you need. Okay. J&J, everybody with J&J is like feeling like nobody's paying any attention to me. So what should they do? And there's a couple of weeks ago, it seemed like it was a no-brainer that if you got J&J, you probably get an mRNA. And then a study did come out, at least preliminary, saying the second dose of J&J worked pretty well. So what should a J&J person think and do? Maybe start with Peter.
So I think one interesting study that didn't get a lot of press was a J&J study looking at, it was very small, 17 people, and they followed them for 6 months. And it was interesting because their antibody levels it was horizontal. They didn't decline like Pfizer or Moderna. I thought that was very intriguing. And then of course, there's a J&J study showing that the second shot increases antibodies, but that's not surprising. I think if I were a J&J person, I would feel like what, J&J is probably, many people believe J&J is really conceptualized as a 2-dose vaccine series, not as 1 dose. And that was mainly pragmatic. So I would probably want them to get an additional dose depending on who they are, especially if they're over 60.
But you would get a second dose of the J&J, not an mRNA.
No, I would get any dose as a second dose, but I'll get a dose. There is mixing and matching studies that we didn't talk about,
right?
Not J&J, but with AstraZeneca, and it was safe and effective.
Yeah, but I'm getting this question all the time. So when I get it, and because I don't know anything, I'm going to tell them what you told me. So if you got J&J as your first dose and you're over 60, let's say, would you say you should get a booster? And they say, all right, which of the 3 should I get? What would you tell them?
I would tell them to get an mRNA. Just right now, from what I know, I mean, the mRNA vaccines give you a code for more of a spike protein than J&J does. But again, that's more not based on clinical data so far. And again, more speculative.
Okay.
And then I know that mixing and matching is safe.
You had to get.
But the one thing is,
Go ahead,
just the
Mom.
one thing to wait on is the Ensemble 2, which is the 2-dose Johnson & Johnson. They are saying we're gonna get data at the end of this month. That is the 2-dose, and it will have been conducted during Delta. So I'd probably hold out and wait for that data.
You tell them to wait for a sec. George, anything?
Just a little while.
You can do both, You can hold out and get the mRNA vaccine while you're holding out, right? So
There you go. All right. And then maybe final question, natural immunity. Some studies have come out and said it works pretty well. So how long is it working for? What are we seeing in terms of waning immunity for if you had your prior infection, let's say in 2020?
I think the best study for me recently comes from Kentucky, where they looked at people a year ago in 2020 who got regular COVID, and they followed them in the same database. And if you were vaccinated, you would, or if you were unvaccinated, you were twice as likely to higher odds of getting reinfected with COVID. So what it says to me is that, yes, you could get reinfected even if you got it before. And then number 2, vaccines rule, but we knew that already. I think reinfection is not that commonly described, but at least in this Kentucky study, it's definitely a thing. There's some studies that illustrate that maybe it lasts a year, but there's 1,000-fold difference in some studies in one individual response versus another to natural infection.
That was a case.
Some people have a vigorous antibody response, and some people not so much, and you don't really know who you are, so you could be at reasonably high risk.
Yeah, just to be careful about that Kentucky study, that may be on the list of how not to do case control studies.
Yeah, I was gonna say that same thing. I wouldn't pull that out as the only study. There's plenty of studies.
Although it's quite compelling, I'll give you that.
Yeah. No, I mean, to be really fair, you have to look at the science of studies and prospective studies. Some even show reinfection rates are lower after natural infection. So again, like, let's be fair. You really want to be fair when you present, because then you'll be more trustworthy. You don't want to pull out like the badly done studies. So I would just say, I don't think we know, but I'd get one dose, and that's my recommendation, because there's so much data that.
So if you had a documented prior infection based on what you know today, you get a single dose of an mRNA.
Yes, and that's what Italy, Germany, Spain, France are all doing, and they're smart. They think about immunology.
And they've been doing it for a long time too.
Yeah,
it works. All right, we're out of time, but I can't help myself. We can go over a minute or two. Just last question. Tell us what the 6 months life is going to be like. It's sort of the end game now is so hazy, and is there going to be another surge coming, or in the Bay Area, we're going to reach a point where the immunity actually is high enough to beat back Delta? What do you think? What are you telling people about the future? George, go ahead. When you start.
Sure. I mean, I think that I'd be curious what Monica and Peter think about whether we could see a worse variant, a more transmissible variant than Delta. I mean, there are a finite number of amino acids that can substitute. I don't know kind of mechanically whether that's really going to happen or not. I think that we can reach herd immunity. Herd immunity, remember, is R naught minus 1 divided by R naught. So if the R naught for Delta is 6, that means you have to get to 84% of everybody, or at least everybody over 6 months of age. So it's going to take some substantial amounts of pediatric vaccination to get there. Monica's absolutely correct. You have to add in and Peter too, you have to add in the natural immunity. Unclear whether that wanes or not, but it certainly seems like there's a wall in East Los Angeles and stuff where where we're not seeing kind of ongoing outbreaks of disease. So I think that, I think we're getting pretty close. And I would, if I had patients who had prior confirmed disease, I'd tell them to get a single dose as well. I completely agree with that.
But the point is, if we can get to 85% immunity and real lasting immunity, either from vaccines or from a prior infection, and it hasn't waned, you think based on what we know today, that will be enough to exert considerable back pressure on cases and prevent a big surge in the future, but you're still worried about the next Delta that's even better than Delta.
Delta plus, yeah, but it's Miller time then, Bob.
Yeah, right. Okay. Peter, what's your take on the future?
I agree with George. I'm probably slightly more pessimistic that we won't necessarily reach herd immunity, because our borders are so porous and there are people moving in and out of San Francisco all the time. And, I just don't know where they're coming from. I'm hopeful that that's the case. I do think that this winter in particular is going to lead to a lot of confusion with diagnostic tests, because you're going to have influenza or COVID potentially, or RSV, and you could have, bypassed that sniffle before if we still are seeing COVID, and that will be very confusing to a lot of people. But I'm also optimistic, and if anybody's going to do it, we are going to do it in the Bay Area.
Yeah, Monica, what's your last word?
Yeah, I mean, I always think about HIV and how it gets hemmed in by its mutations. I think a really important principle of evolutionary biology is like what George said, you can't keep on going. You can't keep on going. This is a really transmissible variant. I am very hopeful that this is that variant that was the most transmissible. It's going to give a lot of people immunity who decline to get vaccinated. That's not ever how I'd want people to get immunity, but it will. And I'm actually pretty hopeful. I don't think we're going to eliminate it ever. I'm sorry. It's going to be endemic, but it's going to be low grade, sitting in the environment, outbreak here because this group decided not to get vaccinated of severe disease, but it's going to calm down and it's going to be this low level virus. And I think this is going to be the last of it.
All right. Well, I hope that turns out to be right. I have to remember our
Surprises.
conversation in May where we had a similarly optimistic outlook, and then Delta came along. So obviously, this thing has to continue to humble all of us as time has gone on. And but let's keep our fingers crossed that we are getting to that level. Thank you, the three of you. Fantastic and interesting and honest. And you know, this is the best information that people can get out there. It's not perfect because information continues to evolve, but really appreciate you sharing that with us. Thank you to my team putting this together. You see them listed up there. We'll be back next week for a non-COVID grand rounds. We'll do a clinical case presentation, which will be fantastic with Robbie Geha, and we will go on from there. This will be posted on YouTube tonight for those that didn't get a chance to watch. Stay safe, and we will talk to you next week.